You are free to start your presentation.
First of all, thank you for the nice introduction, and of course for the chance that you have given me to, not to give a lecture, just to share some of my passion about restorative dentistry. And I always say this, I never lecture, I'm just sharing a lot of things that I wish I've learned when I was younger, because back in the day, of course, we didn't have access to such amazing tools like live webinars like this one, or online courses like the one that I did. And one of the purpose of putting everything together, or such things together, it was actually to give the colleagues the chance to at least not to learn from their mistakes, but to learn from our mistakes, like we did in the past. So this is amazing, the fact that we can expedite the process of learning just by being able to put up this content, which sometimes is live or online, like this one, and help others go faster in life to achieving these results without the struggle of failures and everything. So I will try to share my presentation. Just a second. I was closing my WhatsApp recently because we don't want to be bothered by anyone WhatsApping me. I'm still in the office, by the way. I'm working today. It's just that I didn't put any patients at this time. However, I was able to hear parts of the lecture, and mainly the last lecture of Dr. Stefani, and I must say that I was impressed, and of course we learn a lot from each other. So my name is Dr. Calin Pop. I'm a restorative dentist from Romania, and in 2017, actually this was my clinic in Romania back in the day, a small and boutique clinic oriented towards, I would say, high quality dentistry, slow dentistry. However, in 2017, due to some circumstances, I decided to relocate in Abu Dhabi, in UAE, first in Abu Dhabi, where I had a chance to put up together some live courses with Dr. Anna Saloom, who I respect a lot professionally, and also we became good friends. And recently I also joined another clinic in Dubai. And now my situation is that I commute a lot between Dubai and Abu Dhabi for my profession. Whoever knows me already, they know that I'm a maniac about rubber dam isolation, recently about dental photography, because I've launched a product which is related to dental photography. But first of all, the things that relates most with restorative dentistry is rubber dam isolation. And of course, in my opinion, rubber dam isolation should be a standard in modern dentistry, because the core is the scene where restorative dentistry performs and where adhesion is fulfilled at the maximum. And when I say modern dentistry, what is modern dentistry? Maybe some of the attendants of this webinar, maybe they are young dentists and maybe they have skipped the period of amalgam fillings or maybe porcelain fused to metal crowns. And hopefully they dived directly into bonded dentistry, which is the core of modern dentistry. We can say, okay, let's leave beside the modern aspects of modern dentistry. Let's say, let's leave behind the 3D printers, the scanners, the smile design, the lasers, and many other wonderful things that indeed we should be grateful to have them in our lives. But what is the final fruit of this modern arsenal that we use in our work? The finality is that we will have eventually a piece of ceramic that we have to attach on the tooth in the best way we can. So being modern dentists, we are the slave of adhesion. We are the slaves of adhesion. We have to commit entirely to the adhesion process. Being a modern dentist, that means that we should rely less and less on the mechanical retention and devote our attention to what we can do best to obtain perfect adhesion. So for example, if I show you this case, a patient that I saw recently, and he came with, I would say, not debonded crown, but de-cemented crown. And you will understand why. Because that was the situation. So in this case, we saw, let's say, modern dentistry in terms of materials, okay, because this crown was an Emax crown. But the dentist used modern dentistry to fabricate a crown, and then he used an old conventional dentistry to deliver the crown. Not to mention that the rubber dam was not used, but forget about what was the purpose, forget about this. What was the purpose of doing a crown from a ceramic material that you can etch and bond if you use conventional cements instead of bonding? And then I took a picture of the entire mouth and I asked the patient, because obviously has, except this part here from the canine on the upper right of the patient, everything was done in Emax crowns. And I asked, did the same dentist do all the crowns? And he proudly said, yes, my dentist is one of the best dentists in my country. He's using only modern 3D machine that are cutting the crown, some robots and so on. We know the technology, it's the CAD/CAM technology. And I didn't comment anything, of course, it's not polite to do, but I just asked, can you let me know, how did your teeth in the back look before having the crowns done? And he said, I actually had some fillings in the middle of the teeth, but my dentist convinced me to do crowns because the teeth will be stronger with being restored with crowns. And ask, okay, how about the lateral side of the teeth? I like to ask these questions. It's like a detective approach, just to understand the process. So I asked, was the lateral of the side of the teeth, was that filled? Did you have any fillings on the lateral side? And he said, no, just the normal filling in the middle of the tooth. I had the old black fillings and I understood that he had amalgam fillings. However, my dentist removed the nerve and did crowns. So as I see it, not only the luting agent and the delivery style was not modern in this case, but also the approach and the thought process, the mentality of the treating dentist, in my perception, was not modern, and it was in the disadvantage of the patient, who was maybe, let's say, fascinated by the luxury of the waiting room and the technology in the clinic, which sometimes is just displayed as furniture, because only that was modern, but not the process itself. So let me step aside from this idea and come back to it in a few seconds. This style of non-retentive dentistry is very unforgiving if you don't use rubber dam. I mean, at least in my perception, and I'll show you something to highlight my statement, not only that you lose adhesion, compromising the bonding to dentin, but not being able to properly perform the immediate dentin sealing when you do the preparation, and also to deliver a non-retentive restoration, fighting with the tongue and the pool of saliva in the back, is something that, in my perception, under my skills, it is meant to fail. If you take a look at this case, I literally filmed the same scenario, the same patient, without rubber dam and with rubber dam. And it's useless to mention that for me, it's impossible to work in this area. If I already prepped, they have the temporary filling before I deliver the onlays. But in this pool of saliva, with this strong tongue, with this type of cheeks, for me, it's absolutely impossible to imagine that I can provide better bonding. Not to mention that I cannot do the immediate dentin sealing and all the necessary steps in the process. So to answer my question in the beginning of the presentation, if the rubber dam isolation should be a standard in modern dentistry, I think the answer is obvious. We have to isolate, so we create the perfect chance for us to take the advantage of the new materials that offers us the chance to restore the missing part of the tooth and to be able to connect the ceramic to the tooth at the same values as the original structure was, around, as per many studies, 15, 16 megapascals. So to bond ceramic here at the same values that the dentino enamel junction was before, we should at least provide perfect isolation, not to allow anything to interfere in the bonding process. If I go to this photo, even this photo, in this area, the tongue is literally covering the last tooth in the back, and there's a pool of saliva. So for me, it is impossible to work. So again, being a modern dentist, that should refer to the principles of biomimetic dentistry, in which not only that we have to respect all the principle of adhesion protocol, but also to replace the missing parts of the tooth with materials that they mimic the same characteristics, the same properties of the part of the tooth that is lost. That's why we are replacing enamel with ceramic and dentine with composite with similar flexural strength of the dentin, depending on the area of the dentin that we have to restore. So in other words, we replace dentin with composite, and we replace enamel with ceramic. Of course, maintaining also the proportion of how the original materials were distributed in the tooth structure. Because I will also come to this, why not to make thick ceramics and prep a lot from the tooth, and how to push the thickness of the ceramic, of course, to respect also the indication of the producer in terms of not doing a ceramic which can fracture easily. And to help the process of keeping the ceramic at the limit of the thickness, which in my opinion should be around maybe even 2 millimeters with Emax, we should of course respect some steps in the preparation. Preparation should be smooth, with no edges, no corners, no sharp angles, in order to obtain this optimized thickness of the ceramic. And in the same time, of course, you are less invasive in the tooth structure, and you can avoid pulp exposure. Even if this tooth was root canal treated in this case, you are very often in the scenario of having vital teeth, and of course you should be minimal with the preparation, not to cause a pulp exposure or even pulp reaction. So you don't need to read studies and understand that if you have a sharp corner, even if you have a piece of glass and if you press it against a corner in the room, of course you'll break it. So for this is common sense to understand that all the lines of the preparation, all the areas should be smooth without any sharp angles and sudden transitions. And if possible, all margins should be placed in enamel, even in the proximal areas, if possible. And again, one of the, let's say, the highlights of biomimetic dentistry is not to prep below the height of contour, because you will be with the preparation and with the ceramic in an area where you will meet a lot of tensile forces. So those are some criteria that help us not only be less invasive on the tooth structure, but also to be able to bond in ideal conditions. Of course, if you have this enamel rim around the tooth, of course the bonding process will be easier and more reliable. Just a second. Also, another criteria when you prep under this principle is to keep all the walls out of the contact points. And of course, this is all related with the enamel rim, which is the most valuable substrate for bonding. What about the inner part, the dentin? We should devote a lot of attention to this area, and that means to provide, to do the immediate dentin sealing at the time of the preparation. And there are several, mainly two ways to do it, with 4th generation bonding systems, the one that I'm using here, or the self-etch, the 6th generation. It really depends on the preference of the practitioner. It is a lot to discuss on this subject. I will just continue with with the presentation. So this is the tooth with the enamel prepped ideally for the bonding of the ceramic, the stability of the ceramic, but also I devoted a lot of attention to the inner part, to the dentin, which is prepared for the next step of the bonding of the ceramic restoration. So coming back to this crown, I try to think as a detective and presume that the dentist indicated crowns and then later on cemented conventionally, maybe because of the uncertainty of using rubber dam isolation as an initial approach. Imagine that this was the patient, okay? The patient said that I had some old black fillings in the middle of the tooth. So let's say this is the patient. Instead of the amalgam fillings, he has some normal, okay, composite fillings, but failing old composite fillings. So this is the patient. I would say in the context of modern dentistry, because this is how I started my presentation, a modern approach will be to place the rubber dam before doing anything. And you will see why, because working directly with the rubber dam, in consequence, brings you a lot of advantages that I will explain. And actually, when I say rubber dam first, I insisted so much on this idea, even I published, I was lucky to be published with an article in the Journal of Cosmetic Dentistry, and the title was Rubber Dam First. Not only that it comes first as an importance, but in the process of approaching, let's say, a quadrant rehabilitation, I always place the rubber dam first before doing anything. So this is the patient before. I place the rubber dam. Of course, there are some aspects that I have to take into consideration. For example, I check with the floss if the contacts will allow the sheet to glide nicely through the contacts. If there are some overhangings of some, let's say, even calculus that might be in the way of the sheet gliding nicely through the contacts, I will eventually do a scaling fast, or I will remove some overhanging of the filling, not the entire filling, you will see, just the overhanging, just the things that might prevent the sheet to glide, that's it. But otherwise, I don't remove the restoration at all. And in my perception, this is a modern approach. Because let's say a more classical approach would be to say, let's remove the restoration, let's see what's left from the tooth, and then let's decide what to do. So for me, before deciding what to do, I actually place isolation. And even in this case, I didn't know that this tooth will be for a filling and the next one will be for an onlay. I decided in the middle of the treatment. But at the time of this decision, everything was ideally prepared for me to do the next steps in perfect conditions. So I place the rubber dam before the preparation, and then I start removing all the restorations and the caries and evaluate the tooth structure. So then I know that I can eventually do a direct restoration with having this perfect isolation established. I can do the immediate dentin sealing. Okay, I will finish the restoration also on the premolars, the directs. So all the directs are done in the same session. I do the immediate dentin sealing. This is an old case. I would have constructed more biobase in this case, but I'm just showing this case just to show the difference, just to show the ergonomy of the quadrant dentistry, where I perform also composite restorations in the same quadrant, and the immediate dentin sealing in the same session, and in the next session having the same type of isolation, because if I show you the two photos, you might be tricked and understand that and think that actually these photos are from the same session, but they are not. This is the preparation session, and this is the delivery. And the rubber dam is in the same way placed on the teeth, because I rely on a specific protocol. And then, of course, we deliver the ceramic restoration. So to add a checkpoint in the definition of modern dentistry, it's also to understand that not only that we should use rubber dam, but I try to place the rubber dam always before touching the restoration. For example, this is a case where I intentionally remove one restoration just to show you the challenge that I met. So if I don't place the rubber dam before, I will have a lot of bleeding from the gums. I will have sharp margins that will be in the way of the gliding of the sheet around the teeth. If I don't remove the calculus before, I also have calculus between the teeth that might be in the way of placing the sheet. So now I'm struggling. This is me again, trying to place the rubber dam. Some of the time the rubber dam will tear in this area because the margins are sharp. So that's why I prefer to place the rubber dam before. And you will ask me, okay, what if I have this scenario? Should I remove the filling and place the rubber dam? And I will say no, even in this scenario, just strip the filling. I mean, you will remove the fillings anyway, yeah? So instead of removing the entire composite and having some sharp margins here, even in the proximal area, I just take a thin burr, I just strip the contact, I place the rubber dam, and then I do some additional steps that I'll show you with the floss ligature, and surprise, the rubber dam will be nicely inverted in the proximal area. And it offers me the chance to go inside and clean properly and restore properly, having a perfect isolation. How is it possible that, so let me go back just 1 second. I basically take advantage of the overhanging of the filling, okay? And this overhanging will help me glide the sheet under the margin of the filling. Basically, the filling, the old filling will help me glide. If the filling is missing here, I will have the deep margin of the cavity, which will be in the way of the sheet gliding at a lower level, in a level where actually I want to grab this part of the sheet with the floss ligature and invert it, because you notice that the rubber dam is inverted in this area. It's not enough to just pass the sheet over the tooth. The secret of the perfect rubber dam isolation is to invert the sheet. Rubber dam inversion is when the sheet is inverting in the sulcus, between the tooth and the sulcus and the gingival margin. And only in this way you have perfect isolation and you can restore properly. And the secret is actually to have what's common in all these photos. Even in this photo, let me go back to the other photo. If you have a look here in this area, I have floss ligature. This is also, let's say, a modern approach in rubber dam isolation to not only to place floss ligature on the exposed teeth from the quadrant, but also to place the floss ligature on the tooth that has the clamp. Because what's happening, you might obtain good inversion in this area just by pushing the sheet with a spatula or with a probe. But under the sheet of under the beaks of the clamp, you don't have access to push with anything. So the only way to invert in this area is to put the floss ligature over and under the clamp, and I will show you how. So the quadrant is exposed, and you cannot do it alone. You need the help of your assistant because it's a 4-hands procedure. Basically, your assistant needs to help you holding the ends of the floss ligature while I am manipulating the loop to go over the bow of the clamp and over the beaks of the clamp. And only after I reach this position, I will eventually take over the ends of the floss and continue with tightening the floss ligature. And while the floss ligature is tightening, it has no place to go in the mesial area than in a deeper position than than the beaks of the clamps. Because the beaks of the clamps, they are already positioned in a deep level, they act as a fulcrum and they will force the floss ligature to go in a deeper position. And this is crucial, especially when you want to do deep margin elevation or even to restore simple class 2 composites, where you have the challenge of meeting these deep margins. So I'm not sure if this is possible technical from a technical point of view. For some of you who are watching the presentation from a computer, you can take your phone and scan this QR code, and you will see a free video with my floss ligature technique. And save the link for later and you can watch this video. Or you can do a screenshot of this QR code and access it later. So let me go back to some steps from the preparation in this style of biomimetic dentistry combined with rubber dam isolation. You notice again that I place the rubber dam before doing anything. Yeah, I don't touch the tooth. If I will have some overhanging within the teeth, I will just reduce them with a diamond strip or with a burr, just enough to let me glide the sheet through the contacts. And again, modern dentistry, I already know that I will do an only. Why? Because I see the cracks in the tooth, I see the overextension of the previous failing restoration. So a modern approach will be, again, to prep directly for the restoration that you know that you will provide. So I don't remove the composite and then I evaluate the thickness of the hole and then later on decide that I will do an onlay or an overlay. I start directly prepping for this type of restoration. So I'm doing the gross reduction and the removal of the defects and caries. I don't care too much now to refine the preparation in the proximal areas because I know that I will refine them after I will do the immediate dent and sealing. I proceed with the caries removal. I make everything smooth with a big round burr. You notice that I always use long shank burrs just to have visibility. Otherwise, if the burr is short, the head of the handpiece will cover my field and I will not see properly. Again, maybe I'm too old. I'm still using fourth generation bonding systems. When I do the immediate dent and sealing, you can use the sixth generation if you want, a self-etch adhesive system. So how can I do the immediate dent and sealing in an area which will float in saliva, cotton rolls, and the tongue will cover the teeth? Of course, I will not be able to do these steps, which rely not only visual access, but also the comfort of working slow and respecting all the steps from the protocol. Bonding, then flowable, just to mimic the parapulpal dentin because I'm close to the pulp here. So in this area, we'll not have ceramic. We are building the dentin. And because I had a lot of cracks in this tooth, I prefer to reinforce the hybrid layer with rebond. I'm a big fan of this fiber reinforcement process. I just like it. I just love it. Again, a very meticulous process, which is only possible with isolation and proper exposure of the working area. I embed this remote fiber in a layer of bulk composite, which is not cured, of course. And before curing, I add another layer, and I'm sure that the rebond fiber is completely submerged in this composite layer. I take my time to spread it over the surface of the tooth. And this is actually what many colleagues they call biobase. It's not actually something biological. It's just a layer which, let's say, it mimics the biological part of the tooth that is lost, the dentin. So I take my time to make this layer as uniform as possible, even add another layer of flowable. Just the purpose of this last layer is just to help me obtain a smooth surface. I block the oxygen to remove the oxygen inhibited layer. And it is only now when I will continue to refine the margins of the enamel margins. And I try not to remove the part that is sealing the dentin. Very gently, just just enough, just to make it smooth, that's it. But very carefully not to remove the composite, because otherwise you will re-expose dentin. And again, very carefully to remove the J margins in the proximal area. Ideally, I should have opened the contacts like I was mentioning in the middle of the presentation. But just because I've tried to be less and minimally invasive, I prefer not to. And the last step is to polish the enamel margins with Arkansas burr that I modified. Now I don't care too much if I touch the neighbor teeth, because the Arkansas stone would not actually grind the enamel. It's just polishing. So eventually this is helping for the future contact points if I polished a little bit from the proximal walls of the neighbor teeth. I scan with, with the rubber dam on. I'm not sure if you saw a small trick. I actually retract the sheet a little bit just to allow the scanner to see some gums, just to have some reference of the previous situation. And this is the delivery step where I will brush and pumice. I will clean even if it was only one day between the two sessions, I still prefer to clean. I still prefer to sandblast not only the enamel, but also the biobase, which is composite, even if the composite can be still called fresh composite, and it's good to bond on it already after only one day. Since I'm sandblasting the enamel margins anyway, I don't mind if I sandblast also the composite from the biobase. And of course, I protect the neighboring teeth with a metal band. And look what's happening actually. If I didn't protect the neighboring teeth, this sandblasted area will be on the neighboring teeth. I'm doing the trying again with the rubber dam, just to make sure that the rubber sheet itself didn't move the teeth towards the mesial, because this is a big challenge, especially in the posterior area, especially in the lower posteriors. If you don't use the proper sheet, if you don't use the proper technique to place rubber dam, basically the teeth will migrate to the mesial, and you will have tighter contact points, and you will be surprised to find out that you cannot insert the restoration. What I'm doing here, I'm actually, and this is why I'm always etching the ceramics myself and I'm seeing with my loops. Sometimes the technician by mistake, they glaze the intaglio of the surface exactly in the region where I need adhesion the most, which is the enamel area. So if the glaze was there, I prefer to sandblast, to remove the glaze and just apply another round of etching in that area. That's why I don't let my assistant to do the etching of the ceramic, because I want to see what's happening. I want to see how is the etched surface of the intaglio of the ceramic. If there is any glaze, I prefer to remove it, because this is the most critical area. This is where we have adhesion the most, on the enamel rim. And if the glaze is on the ceramic in that area, of course, we will lose adhesion. I isolate the neighboring teeth. I like this process so much. I actually here, I don't work, I am playing. This is my playground. And of course, you can only have this level of satisfaction again if you provide good isolation. Literally, I can go out from the room for 1 hour. I'm exaggerating, of course. And I know that the situation will remain the same. I can rely on the position of the sheet, on the stability of the rubber dam isolation on this teeth, just because I applied a lot of small tips and tricks to establish such an isolation. I'm using heated composite to deliver the restoration, and that was only possible because I optimized the cavity, the prep surface, in such a way that I will not do a ceramic which is unnecessarily thick. If it's thicker, of course, you cannot rely on the composite to be fully cured under the ceramic restoration. A small trick will be to use this transporting instrument, which is just an instrument with a ball-shaped end. I use the liquid rubber dam to kind of hold the restoration in during all these phases of etching, sandblasting, and all the steps that you saw. It's good to also have this instrument that is vibrating the restoration, just to help you extrude the composite. And I noticed actually some guys are against it. I noticed that even if I pressed with my fingers and I thought, okay, this is the this is enough. After I used the instrument, there was more composite extruding from underneath the restoration. So I think this is quite useful. See the composite extruding more? I try to remove as much as I can before curing. So I'm using this silicone brush to remove all the composite. I don't cure. I take my time. I actually work like 4 hands or like at least 2 hands with my assistant. She's holding the floss from the other side. Just a second. Because all this time I'm holding the restoration with my left hand. I should not let go. If you let go, you lose the position of the overlay on the tooth, and you can compromise the bonding. So I'm always maintaining the position. She has the blue gloves, I have the normal gloves, and we dance. Like I'm telling her, now you drag from the floss, now I'm dragging from the floss. And this is how I actually remove all the excess of the composite from the interproximal area. Again, even if I switch my hands and I'm holding with my right hand, I'm still maintaining the position of the overlay. I'm removing everything. And only after I'm sure that everything is cleaned and I evaluate with my loops. I have a camera which is on my loop, so whatever the camera is seeing, I'm seeing. So only after everything is clean, we cure. It's also important, even in this step, even for this tiny thin layer of composite, it's important to block the oxygen for the final cure. And then the normal protocol in removing the excess of the composite with blades. But notice, even here, I maintain the sheet as much as possible on the teeth. I don't remove the sheet and then clean the excess of the composite. Even when I'm using this brownie to remove the excess of the composite, I'm still with the sheet on. First of all, I have better visibility. I still have light. There is no bleeding from the gums. I have a lot of space around the working area. And also, if you think about the airborne contamination, as long as you keep the sheet on the teeth, you will eventually mitigate the risk of infections in your dental office by decreasing the level of airborne contamination. If you use rubber, then of course everything will be isolated and you will have more control. So that case was quite easy to isolate, no? You might say, because the margins were up. What about this case? Because here, if you have a look, the filling goes a lot significantly under the margin of the gum. And again, you might say, okay, I will prep, let's see what's left from the teeth, and then I will place the isolation. Even in this case, rubber dam was placed before. So before doing anything, I check with the floss if I have some overhangings, if I have some things that might interfere with the sheet gliding through the contacts, and only then I place the rubber dam, I remove everything, and notice what's happening. Because I placed the rubber dam before, and because I placed the floss ligature, by the way, here I have a floss ligature. You cannot see it because I like to hide the knot on the lingual side, just because I'm a maniac with photography. I don't like to have any knot here. Also, because sometimes the margins are quite deep and it's actually more frequent to have deep margins on the buccal area than the lingual or palatal area. So if I have a class 5 restoration, I prefer not to have the nods, the nod of the floss ligature in this area. So I prefer to rotate somehow the floss and cut it as short as possible and hide it in this area. So because I placed the rubber sheet before, and because I placed this floss ligature that is pushing the sheet and is fighting, the floss will meet the resistance of the height of contour. It will pass this level. It will pass the level of the overhanging filling that I have on the proximal area. The floss doesn't have anywhere to go that under the filling and over the margin of the preparation, because the preparation here is under the filling, but is not exposed yet. Only after I remove. Now it's imagine you have this scenario. It's quite difficult and it's quite challenging to place the sheet above and isolate this deep margin. However, if I press the rubber dam before, I was able to obtain this isolation and do all the steps with immediate dent and sealing, exactly like I've told you. Let me just not to make the presentation too long. I'm not sure. Please stop me when I approach the end of the time that I'm allowed to speak. I'm just showing you a part of the preparation. So look how nicely, I placed the rubber sheet before, and look how stable is the sheet, despite my attempts with the burr in this area. Okay, I have the freedom to clean to remove the old composite, to properly clean the caries. And all this time, the sheet is stable in the sulcus. And this is only because I pressed the rubber dam before. The delivery process, the rubber dam is in the same position. Indeed, now is more challenging to place the sheet. However, with some skills, you can do it. And the delivery process. And this case was actually done maybe 4 or 5 years ago. And despite the totally non-retentive shape of the preparation of the tooth, by the way, to reinforce the principle of biomimetic dentistry, where against the conventional dentistry, in which many dentists would have done a root canal here, maybe posts and a crown. Because I had this gold, this enamel rim, which is not a lot, but there was still something, the restoration is still in the mouth. Of course, proper bonding and proper protocol in the preparation process. So it's literally, there is almost nothing from this tooth, but I still have this enamel rim in the most part of the tooth. So it is this approach modern dentistry. I'll name it courageous dentistry or courageous modern dentistry. Because I must admit, back in the day, long time ago, I would have referred for RCT and crowns. And actually, this is the perfect example of how I can convert conventional dentistry in modern dentistry, primarily because of the rubber dam. So all this was possible because of the fact that I was confident in my rubber dam isolation. Should I understand that I should end my presentation? Alina?
Yes, yes. So, wow, Calin, I just can say, wow.
I'm not sure if I can hear you. So if you want me to stop, just just make a sign.
Respect. I think the time is now to change,
so anyway,
but when you have 3 minutes,
just to make a small, I cannot hear. I think you should open your microphone.
No, you can do it. No problem. No problem.
As a small conclusion, and it's not a joke, but actually dental photography, which you saw a lot that I overused in my case, in all my photos. It's a chain, basically. Dental photography will help you convince the patient to do more work than normally, because with proper dental photography and proper explanations, you will actually convince the patient not only to address the problematic teeth in one area in the quadrant, but also to address other teeth that are next to the main problem, which is very visible for the patient. So dental photography helps a lot the biomimetic dentistry approach. Okay, and dental photography will actually translate into a bigger conversion in your cases. And biomimetic dentistry approach combined with dental photography can actually be more profitable, because you can transform this simple one-tooth approach into a full quadrant rehabilitation, or even in a full mouth rehabilitation. So it's actually more profitable, if you ask me. So I think I should. I have a lot of slides. I can continue for like maybe a few hours in this direction. I just want to thank everyone, and feel free to reach out to me on my channels, Instagram, Facebook, even YouTube. This is my email, and I cannot end without product in dental photography, which is a setup of soap boxes that you can attach directly on the camera and do this nice photography that I've shown you in my presentation. And this is, okay, let's say to convince the patient, you can use simple flashes or simple lights that are not diffused. But for whoever wants to level up their game in dental photography and they want to obtain this kind of photos that are worth enough for the cover of the prestigious magazine, I think light diffusion is amazing. And in this very ergonomic and practical form, it's very accessible and very useful to use it in our daily work, because we don't have a photographer next to ourselves. We have to do the photos by ourselves. And this is quite practical to have a tool next to you that is always ready to do this kind of shots. So thank you very much again for the chance of presenting some of my experiences in restorative dentistry. This is not a lecture, it's just sharing some way of doing things. And I really hope that it has some impact in some colleagues that for which this approach was different or new, and they can apply in the daily work starting with tomorrow.
Wow, Calin, applause for you.
Thank you very much.
Very, very nice, great presentation, and this is really modern and slow dentistry. I have just a question. How much time do you need to insert the rubber dam in the posterior area?
It should not be more than 5 minutes.
5 minutes. Okay.
Yeah. Okay. But this, okay. I do rubber dam isolation as I breathe. Okay. And I'm doing it for so many years. I actually discovered rubber dam isolation in the 3rd year of university. We were in Cluj, and because of the cooperation that our university had with another university in the United States, they brought a lot of, like, say, modern dental units and a lot of new materials at that time, which was amazing. I was in the 3rd year of university, but they also brought some rubber dam kits. And everybody in my group, they thought there are orthodontic devices, you know, because of the forceps and everything, and they ignored it. However, I was very curious, and of course, I Googled it. Imagine Google at the time. It was only in our university campus in a lecture room with 2 computers, and this is how I discovered it. And slowly, I started to embed it in my daily work. Let's say, for me, it's 5 minutes. Let's say for an experienced dentist, is 10 minutes. Okay, 10 minutes that you spend in establishing proper rubber dam isolation, you lose when you place the rubber dam isolation, but then you will gain it by working continuously, focused on your work, not letting the patient spit every time after every 1-2 minutes and interrupt your work. And some patients are over talkative and they talk a lot and they interrupt you and they say, "Give me the mirror, let me let me see what you did." So, or like placing retraction cords or this astringent paste. Okay. So these 10 minutes, you will save it later on in the process, or maybe even more.
Yes, you have a perfect restoration, and you don't need to repeat this in 1 year. And I think the 10 minutes are very important for us.
That 10 minutes will eventually translate in maybe hours of working. Eventually, if you repeat the case, if you don't do proper immediate dentin sealing, if you have pulp reaction, and you have to cut the nice modern only that you did, of course it will translate in more and more time spent. And not only this, frustration and disappointment from the patient from your side, and you will actually bring on yourself a lot of let's say lack of confidence.
Okay, thank you very much, Calin, and
I thank you again.
Maybe you can be next year for the study club number 7, yes, in Germany.
I really hope so.
So